Hi there, I'm Jennifer Aloff. I am a family physician in Midland and part of the Great Lakes Physician Organization. Our practice, like I said, is in Midland, Michigan. It's a suburban area, headquarters to Dow Chemical, but a town of about 50,000. So we had been on the Allscripts Pro EMR for about 14 years, and then this spring undertook the adventure of transitioning to a Prima in May of 2025, which presented some interesting challenges and opportunities. I am currently the only physician in our practice. We have 3 nurse practitioners, 1 PA, and 2 RN care managers. Like I said, I'm in an independent practice. We do have a CLIA waived lab, so we do urinalysis, we do hematocrits, we do have a lab standard A1C machine, so we do finger poke A1Cs in the office. And then we do urinalysis. I think I said that already. And we have a total patient population of about 5,200 patients. Next. So we had 120 MCT2D attributed patients, and our baseline performance was at 91.67%, I'm pleased to report. So what do I think are our real keys to success? The team-based data-driven workflow is the number one thing. It doesn't rely on any one person making sure to capture all of these. We have a multi-layered approach to making sure that everybody pulls together to try and catch the people who are falling through the gaps. We work hard to try and address any barriers to patient completion, and then the in-office collection of the urine sample at the time of office visits has been really crucial to closing our gap list. And we'll go a little bit more into detail on these as we go forward. Go ahead. So we'll talk a little bit about the team-based process. We do have an annual flow sheet for all of our diabetes-based quality measures, and there's a copy of it at the end of my slide set to give you an example. But it does include the urine albumin creatinine ratio, lipid panel, retinopathy screening, their A1C, do they have treatment for diabetic nephropathy, and other diabetes or non-diabetes care measures such as their cancer screenings, immunizations, et cetera. So before each office visit, the MAs do go through and prep each chart, looking back at what labs have been done. They record both when these metrics have been completed and then when were they coded last. So we're making sure we're capturing not just the completion of those, but coding the F codes to make sure that those are being documented within our office notes. And we do have a rolling reminder system where we will put a note in the chart when the next screening may be due. So we do have actually a quality manager who goes through, we use a patient registry called Health Focus, which is one that is provided to us through GLPO, and we use it for managing not just diabetes quality measures, but across our ACO and our value-based care payments. We can use it to look at claims, and it's a very, very robust tool. And so she works the gaps list, and we'll put a pop-up in the chart when a gap is outstanding for that specific patient. So that's an additional reminder for the medical assistant and for the provider, because it'll be facing both of us when we see the patient. And then the thing that really boosted our performance from the 80s to the 90s was when we made arrangements with Quest to start obtaining our urine albumins in the office and sending directly to Quest via pickup. So patients who haven't been completing it at the lab, we can capture it right there in the office. Go ahead.
There we go.
Thanks. So we just talked about the flow sheet, and like I said, we'll have an example below, and then Health Focus, which is really a robust patient registry. And there were some increased challenges for us when we transitioned from Allscripts to a Prima. So we had a built-in flow sheet for quality measures in Allscripts, which we haven't yet quite figured out how to implement in a Prima. I think they do have what are called clinical decision rules built into a Prima. So I think once we have been on that tool for a year, we'll be able to build those in, or maybe with the next calendar year. So that's something still to come, because it would be nice. We are doing it now the MAs are pulling a paper flow sheet, so it's not as efficient as doing it right there in the EMR. So this is an example, and the first column there on the left would be the last, when it was last completed, and then the right column would be when it was last coded. So you can see that those are kind of the things that we have been tracking, including their foot exams and do they wear diabetic shoes. If they do wear diabetic shoes, then we know that the physician has to provide the diabetic foot exam. Otherwise, the nurse practitioners or PA can do it. Are they on a statin is another thing that we are tracking regularly. And then when the roomers room the patient, we actually have a set template that they use to track what things are outstanding. So it'll say right on there, when I go to pull the patient's chart, patient is on a statin, has their eye exam and A1C and urine microalbumin are up to date, and they need a foot exam today. And so that's very helpful. Our RN care managers, if we have specific patients that are having barriers, we can arrange home blood draws, or they can help with transportation to help patients get to the lab, maybe interface with family members to coordinate care and make sure if patients aren't understanding, especially in our geriatric population, getting their labs done ahead of the visit so that we can more effectively communicate about their results. Then our RN care managers will work with those patients to help them. Our clerical staff, as we said, maintain our gaps in care list and monitor health focused population quality measures. Medical assistants are really integral to keeping the providers on the straight and narrow path. And then sometimes the providers do sometimes find things, like we just realized as Lexi, our coordinator for MCT2D, and I were discussing this meeting tonight, we realized that when we were making the transition to our EMR, some of our lab results were being scanned in as documents because we weren't getting discrete data flowing. So now we have to remind the MAs, don't just look in the discrete data, you got to go check the scanned documents for labs too, to make sure that they're not duplicating orders. So there's always critical thinking at every level of the team. And then the providers, of course, need to act on any abnormal findings. So our biggest challenge was we were sending out labs on a consistent basis as part of the chart prepping process. And the MAs were calling patients and saying, hey, you have an appointment next week. We need to make sure you get your labs done. But then patients were saying, oh, I didn't realize, or I went to the bathroom right before I got to the lab and I couldn't go. So we started doing on-site. And it was easy for us to arrange with Quest because we already had an existing relationship with them. In that we were sending in urine cultures and they do our pathology samples for biopsies and whatnot. So it was just a pretty straightforward thing to develop a workflow and just augment that to what we were already doing. And then like I said before, if we can't get the patients able to do that at home or in the office, then we have been able to arrange some home draws. And I'll just give you one example. Like I had a patient that I saw just last week who's in his 70s. He's a well-controlled diabetic, and we share care for him between the VA and our office. And we're able, he gets his annual labs with his lipid profile and his comprehensive panel and CBC and whatnot at the VA, but they don't do a urine for microalbumin and creatinine ratio. So we were able to obtain a sample right there in the office. We already had done his A1C right there in the office. So then we were able to close the measure, and he was happy to give the sample. He's like, great, I don't have to go to a separate lab. And he was really pleased with that. So that works out very well for those patients. We've also had patients who were like, I can't, the lab closes at 4 and I work till 5:30. I can't get to the lab. And so we've told them, hey, we're open on Saturday mornings. We'll give you a bottle. If you drop it here to us, we'll get it to the lab. So there, we just label it ahead of time. We have the lab order ready to go. And so having the in-office lab accessibility has been really helpful for closing those gaps.
Dr. Aloff, I'm making furious notes. Take home pee bottle. We're going to save questions for the end. And I'm going to position us. Thank you so much for sharing the incredible things your practice is doing. And I just want to appreciate, not everyone likes public speaking. I very much appreciate all of you agreeing to do this tonight.